welcome to Anesthesia Coffee Break. And today, Stan and I, we are going to go through the 2025 exam paper. Hi, Stan. How's it going?
Yeah, good, La. How are you?
Yeah, really good. Hey, so you've done a lot of work. I've just seen your summary of the paper. It looks like I just think every primary exam paper looks brutal to me, over a decade on now. And I'm sure that's what people feel when they sit the exam and look at that paper, but hopefully the preparation gets you somewhere there. And I note the pass rate overall was like 45%, which is pretty...
Well, I think the overall pass rate for this paper was 62% on, if you look at the exam statistics.
Yep.
With the SAQ paper, over 80% actually scored the invite mark of over 40%. But the overall pass rates were 62%, which, if you look back, fits into that band of around sort of the low 60s to the low 70s in terms of pass rates.
Yeah.
So, in terms of where it sort of sits within that band that has been very consistent over the last decade. Like, it hasn't budged at all. Remember that graph that I showed in the last sitting where it was sort of slowly moving up and then all of a sudden started coming down again? And it looks like, again, it's hopefully plateauing.
Within the error margins, it's still about, as in it hasn't gone up so much, it hasn't gone down so much. It's about the same if you look at standard.
Correct.
Yeah.
Yeah. And I thought what was really interesting about this paper was that it definitely had a lot more statistics in it and a lot more sort of interesting sort of numbers that I think we can sort of delve deeper and perhaps, again, good discussion points and see what perhaps some conclusions that we can come up with.
Yeah, sounds good. Hey, so you've done a SAQ summary and classification. Did you want to go through that to start with?
So if you look back when I first started this a couple of years ago, I had this traffic light system where I divided into green, yellow, and red. And green questions were questions which were repeats with a pass rate of more than 40% within the last 10 years. And then what I would describe as yellow would be variations or repeats with pass rates between 20 to 40%. And then red questions are like the hard questions. They are new questions or repeats with pass rates less than 20%.
Yeah, interesting. And everyone can check out on the YouTube video of this podcast just to see what Stan's done with that. So yeah, that's really interesting. So you've generated a few conclusions from this, which is really interesting. How did you feel about the repeats versus varied repeats, etc.?
Well, what was really interesting was if you look back at the previous couple of years, the number of distribution of repeats, variations, and new questions was approximately about the same. But this time around, what I found was that there was probably about 6.5 repeats. And there was a question now, which was the number 15 question, where I felt that half of it was repeat and then the other half was new. And do you want to quickly sort of go through that number 15 so everyone knows which one I'm alluding to, question 15?
Oh, yeah. On the primary exam.
On the primary exam, yes. If you look at the PDF file, if you head over to question 15, it was a question on neuromuscular blockade. And the neuromuscular blockade question was define the following terms: trainer 4 count, trainer 4 ratios, post-tetanic count, and explain the physiological basis of these tests and how they are used clinically. Now, if you actually look back on the previous repeat questions, which was in 2011, there was a question about TOF and DBS, but not about post-tetanic count. So that was new. But the repeat side was about the trainer 4 count and the trainer 4 ratio. So I decided that question was half repeat and half new. So in sort of summary, there was about 6.5 repeat questions, 5 variation questions, and 3.5 new questions.
Yeah.
Now, if you look at it in totality in comparison to what was done in the past, you would say that this was probably one of the fairer exams that sort of came out. I think if you sort of look back over 12 months ago, my conclusions was that it was actually probably a hard exam, the ones that were done in 2004.
Yeah.
And speaking to candidates who did sit the exam, I believe that was the general consensus that they did feel that this exam had a number of repeats in it, and also that they felt that it was fair. But obviously, there was some challenging aspects to it with the airway anatomy booklet.
Yeah, of course. And I know, as we were talking before, you're saying how the repeat questions had high pass rates. Makes sense. But the varied repeat questions had the lowest pass rates.
Yeah. So this was really interesting. And I think there's a couple of learning points that we can pick up from this. One is that when you look at the average pass rates from the repeat questions, they were above 50%. So 53.5% to be exact. Now, when you look at the variation questions, their average pass rates was 35%. And the new questions actually scored above 40%. So they were 42%. So what was a really interesting find for me was that the variation questions were actually the most difficult. And I think it's worth sort of exploring that a little bit more in terms of why that could be.
Yeah, my gut feeling is that people might just rote learn an answer, and they think it's and they think and they want to be asking the question that they prepared for, because it's just the cognitive load of having to think of a new style of answer when when it's so close. And I remember that feeling of in the final exam, there was one past paper that was just GCS, Glasgow Coma Scale, and it was always 12. And then on my exam, unlike 10 years previously, it came out to be 13 or something, or 11, and every part of me just wanted it to be 12. I was like, am I thinking this wrong? And luckily I just went through it properly. But yeah, maybe, what do you reckon, that people are potentially fooling themselves to think it's the same question when it's not?
Yeah, I think you're spot on. And what I think will be a really interesting exercise would be for us to go through some of the variation questions and perhaps see, in terms of, as you said, applying that idea of, this was the question that was asked in the past. And if we had applied the same model answer to that older question, how would it answer this variation question that came about? Because I think that sort of familiarity with that question, you're right. You almost want it to be a repeat question, don't you?
Yeah.
When you see a variation question, and you sometimes almost force the concepts, force the ideas across onto the paper. And I think it makes you feel good, because this is something that you've learned and you've spent a lot of time, and you're an expert in terms of reproducing, one of your learned answers. Mm. But I think you're right. If you don't have that insight in terms of that this is a variation question, and perhaps they're asking something a little bit different, that you may not be answering the question, and hence that would explain the low pass rates.
Yeah. No, it's probably one of the sad things, but I think the knowledge of it is knowing that there's a fact, and there's part of our personalities and I guess our struggles with the exam makes you prepare for it. And you said that this is common through all the other exams. This is consistent. This has been years.
To be fair, I haven't done a deep dive in terms of looking at the average pass rates for repeat variations and new questions. And this time around, I did it just as a exercise, because when I was writing down the pass rates for each one, I noticed in general that there was certainly variation questions which had lower pass rates. So I just wanted to see whether that was actually true or not. And I think it would be really interesting, perhaps if I go back in the past, to actually go back and see what the pass rates for all those three subsections were.
Yeah. Hey, so you've got some recommendations for candidates?
Yeah. And look, what I think we do, Lara, is perhaps let's go through some of the variation questions first.
Yep.
And then after that, perhaps let's think about the recommendations sort of moving forward. For those primarily, I think, who are planning to sit in March next year. Obviously, I think there are a lot of people here who are listening who are sitting in August, and perhaps there is some tinkering that we can do in the next couple of weeks. And I'll certainly sort of factor that in with, some exercises that I will produce as well.
Sounds good. Hey, so the first variation question is question 3. Did you want to just go straight to variation then?
Yeah, let's do the variations, because I think that will take us, for this episode. And I also think that that would be the highest yield, because, let's attack the area where I think has the most need. And it's clear to me that the variation questions are coming out as the most challenging ones.
Yeah, we could have got more people passing if they knew how to tackle the variations as a low-level fruit type equation. So this first question, question 3 on this paper, explain how hyperventilation causes respiratory acidosis, has 25% of marks, and outline how renal compensation for respiratory acidosis occurs at 75% of marks. So roughly 2.5 minutes you'd spend on the first question and 7.5 minutes on the second part. 39% of candidates passed this question.
Yeah. So there was a 2021 question, B11, which was fairly similar. It said, explain the physiological effects of acute hypercapnia caused by hypoventilation. So certainly when you're discussing the physiological effects of acute hypercapnia, you would talk about renal compensation as part of that. And it's interesting to see that that pass rate there was actually 31%. So in some ways, you could say, yes, there has been improvement because of that familiarity with that question there. But certainly, what I consider a threshold is that 40% mark, is scoring that 2 out of 5, for a question that's there. Now, I guess, when you look at that question, if you had a template answer for that, explain the physiological effects of acute hypercapnia caused by hypoventilation, do you think you could have applied that to this question here, La? What do you think?
I mean, can you just say the wording for the previous one?
So the 2021 B11 was explain the physiological effects of acute hypercapnia.
Oh, that's different. Physiological effects of acute hypercapnia
caused by hypoventilation.
No, this is a very different question to me. This is literally science versus this is acid-base physiology versus what are the effects of acid-base physiology on the body. So, the physiological effects would go into, organ function based on high CO2, whereas this...
Certainly I think the physiological effects of acute hypercapnia, you would discuss renal compensation. So certainly I think 3B would be covered by that question in the past. But you're right, in terms of hypoventilation how hypoventilation causes a respiratory acidosis. But in saying that, right, I would think that if you did do a template answer for that 2021 B11 question, you would need to explain how hypoventilation would cause a respiratory acidosis, and that would lead to the physiological effects. And
that'd be quick, though, wouldn't it? It would be at most half of your answer.
You're right. Yeah. So the key point is that because it had a broad category of physiological effects, you couldn't just think of renal compensation. And I think this is where, that depth of knowledge is required, because renal compensation here is all of 3B. Yeah. Whereas when you think about the physiological effects of acute hypercapnia, you could think about other systems as well. You can't just include renal. You'd have to include renal, cardiovascular, CNS as well.
Absolutely.
So
this is interesting to me. Explain how hypoventilation causes respiratory acidosis. That seems relatively straightforward. It increases law of mass action. You've got your, the H2CO3 equation and just transfer. And that's reasonably easy enough.
Yeah. Which is why it's only 25% of the mark. Yeah. So I would think that if you look at it, right, that's only 1 mark out of the 5 that will be attributed to that, or,
yes.
1 and a bit if you did the maths correctly.
So the beauty of this is that this is a renal question in a sense of like the 7.
Yeah. It's really interesting. When I was looking at this, I thought perhaps this was a renal question.
Yeah.
And you're right, but I did put it into acid-base physiology. And
Incorrect.
I think you could argue both, but I do feel that it's more sort of acid-based. And you know what? There is definitely crossover with respiratory and renal here as well.
Absolutely. I would say only renal, because there's 7.5 minutes of someone answering the question saying the renal ability to handle acid is, bicarb reabsorption, titratable acid, and ammonia excretion, and ammonia. So that to me is completely renal, but obviously it's part of acid-base balance as well, because it absolutely interlinked. But I didn't study that in acid-base. I studied that from Vanda.
Yeah.
So this is interesting. So
it's more in depth, isn't it?
Yeah.
So look, I think a learning point from, this variation question here is that if you do get a general question, and I think we'll see other examples in this paper here, when you get other examples of, previous questions in the past, which are very general in terms of their description of what needs to be answered. So for example, if someone says, or if a question says, what's the effect of, X in terms of, the overall effect of the body. So you need to think about all the different systems. But when you study that, you actually need to go into each individual system and actually go into further detail. Not just think about sort of that subset, which would answer sort of that brief answer there, but actually think about it in terms of more detail, which could even lead to itself in terms of like a question itself. So for example, it could be explain how hyperventilation causes the respiratory acidosis. And then the second question in the future could be something like, how does respiratory acidosis affect the central nervous system? So that could be all a part B in itself, or explain how respiratory acidosis affects the cardiovascular system.
Yeah. And
so,
it is good to see that. Just looking at the examiner's feedback, it doesn't look like people confused this question with the previous one, in the sense that the problems recurring are including irrelevant details about how CO2 affects ventilation. Yeah, great. So people, that seems to be the only one that's maybe what happens to your physiology after CO2 increases. Luckily, the examiners are not saying people were talking about the cardiovascular system and its effects with CO2 increasing and CNS. Everything.
Well, it's funny you say that, right? But I disagree, because if you look at the third comment, confusion about what the terms buffering and compensation means. So when you think about the past question that was asked, the previous repeat, the physiological effects of acute hypercapnia, you would include buffering, right? Into your answer here. But this answer is very specific in terms of renal compensation. So you know what your first statement was?
No, they've said confusion about what the terms buffering and compensation mean. Like you would mention buffering.
No, you don't mention buffering here.
Yeah, you do, because how hyperventilation causes respiratory acidosis, there's buffering involved in that, because it's the law of mass action in that equation.
Right.
A bicarb involved. But I wouldn't say a lot about that, because you're drawing an equation showing how CO2 causes acid. That's just an equation.
Yeah.
2.5 minutes.
Yeah. But what I suspect would have happened would be that for 3B, I would think that there would have been some answers there where they would have discussed quite extensively about buffering.
Yeah.
Here. And going back to the point that, this is probably an answer that they've learned, and they're trying to sort of apply it to this subset question.
You know what's interesting? And I think we all experience this on the journey of the primary exam, that like terms mean something, and I think it comes up time and time again when we're vivering, and it's happened to us, it happens to the people we're examining and helping out. But to really know what each word actually means, and not just throw away things like equilibrium and buffering and compensation, whatever other words that have a really important definition. And it happens in the final exam, happens in the primary exam. Anaesthetists are very particular about words, I reckon, especially in the exam.
Well, I think this is where that's the difference between, the written exam and the viva. In the written exam, you've only got one chance to write your definition or to explain yourself. Whereas in a viva, you may get it wrong, but you always have that opportunity from the examiner to actually come back and perhaps redefine or re-explore some ideas there. So I think that's sort of the difference between the two.
Hey, so that's pretty good for question. Should we move to question? I think the next one was question 6.
Yes. So question 6. Let's quickly go to that. What does that one say?
Explain the initial and subsequent distribution across the body fluid compartments of a rapid bolus of 1,000 mils of compound sodium lactate, Hartmann solution, and B, 1,000 mils of 5% albumin.
Yes.
So this seems like a half-half kind of question for each part. 22% of candidates achieved a pass. So yeah, this will be...
Fluids is always challenging, I think. Yeah.
Yeah.
But this was a variation question. If you look back in the past, most recently, 2022 A9, they had a question on discuss the physiological effects of infusing 2 liters of Hartmann's solution over 1 hour in a conscious, healthy, euvolemic 70-kilogram patient. And then if you look back in 2014, question 13, A13, there was compare and contrast the pharmacology of normal saline and 4% albumin. And I guess if you had a template for that, La, again, how do you think that will be similar or different to this question here?
Yeah, so this one is very specific though, like initial and subsequent redistribution. So, you'd have to almost tabulate this or organize this particular answer, showing that very specific part of CSL and the way it moves and albumin and the way it moves. The other one talks about pharmacology of something. I think what you said, I don't have the question.
The compare and contrast the pharmacology of normal saline and 4% albumin. And I think, within that structure, you would be discussing about distribution as part of it.
Yeah, because pharmacology means pharmaceutics, pharmacokinetics, pharmacodynamics.
Correct.
Yeah.
And again, this question is very specific about distribution across body fluid compartments.
Yeah.
And again, it's a subset, certainly, when you're looking at the pharmacology of, or studying the pharmacology of the fluids, you would have, absorption, distribution, metabolism, elimination. But it's one of those ones, and again, similar to what we had in the previous variation questions, where they're honing in on a very specific subset of that idea,
And so I would, I'd still want to write the composition of each, and that's very quick. That's reasonably quick to do. But obviously the broad part of this question, the massive part of this question, is to be able to say the initial and subsequent redistribution, which is that then a really just absorption? That's easy, IV. It's a distribution metabolism for metabolism and elimination. Is that...
Look, I probably wouldn't talk too much about metabolism. I think this one here, you'd have to go and really discuss about the different body compartments. So, how you would approach this question is understanding total body water and the different distribution of fluid compartments in total body water in a human. And then understanding how that differs for both crystalloid, which can be represented by both Hartmann's as well as normal saline. And then also thinking about how that's different with 4% albumin.
Yeah, absolutely. And interesting because both have a specific substance in them, lactate and albumin. So discussing the fate of them featured, we're given extra credit as better answers.
I think if you can sort of incorporate that and tie it into distribution, that helps to answer the question that it's been asked. But I certainly think that the mistake that could be made is if you just write metabolism as a subset, but don't actually tie it in to what's being asked at all. Look, I think fluids are always a challenging question, and especially because there certainly is some differing opinions in terms of distribution of fluid. I think I think when we sort of went through was sort of fairly simple in terms of the structure, but they've done a lot of studies, and Miller's has certainly sort of published this, that it may not always be the case in terms of distributing into the ECF space.
Yeah, and look, I like at least the examiners are giving their frame, the answer domains. If you can say, body water and the relevant compartments and ratios, great. That's easy enough. One kind of core learning, principle of fluid movement, great. So we commonly talk about solids and membrane permeability, so that's easy enough. And then the essential solids of the given IV fluids, determining distribution over time, which is then integrating that initial statements about body water and compartments and fluid movement, and then targeting each of these fluids and describing them. So yeah.
I mean, when I went through, if you remember, and I don't know whether you think the same or not, but we were always told colloids always stayed intravascularly. Is that
Yeah, exactly. And
remember? That's what we were told.
And what was that trial? I don't know if it was a relief trial or the one that the head of starch trial that showed that the difference was 1.2 to 1.4. It behaves very different.
Very different. Correct. It's not just all intravascular. Yeah, correct. Okay. So colloid doesn't always remain intravascular. But again, that has been something that, we've been taught. There's a lot of sort of traditional ideas on that I think are sort of evolving.
Yeah. It was interesting that, so I think, I wish I could remember the exact study, but when they looked at crystalloid resuscitation versus colloid resuscitation, things like gelfusion or whatever back in the day, the extra volume you needed from normal saline was 1.2 times the colloid amount, which is staggeringly different to what you'd presume mathematically based on just the movement of solute across permeable membrane. So the body compensates in many other ways.
Yeah. I mean, I do remember sort of doing this question and doing like a deep dive of this question of the 2022 A9 question. And I do remember that, there were some sort of challenging aspects with the concepts that were, that had to be sort of discussed there. So again, I think that sort of shows the importance that when you sort of do the repeat questions, have a think about the possible different sort of combinations that could be out there. Because, with this question here, instead of sort of looking at it in terms of normal saline and 4% albumin, it was like looking at Hartmann's and 4% albumin. And you had to incorporate some of the knowledge that you did in the 2022 A9 and the 2019 B10 question about sort of learning about the Hartmann solution over 1 hour in a conscious, healthy, euvolemic patient. Yeah. But this would be something that I would definitely focus on. Probably not for August, because it's, in my experience, I've only seen one time where a question has been repeated from subsequent exams. It's always,
oxygen one, I think. That was they had the oxygen.
Was it? Yeah.
Oxygen delivery and in the way you can do it. And then it's like 22% pass rate. And then they gave it to us in the next exam.
Oh, did they?
Yeah.
It's very rare. I think that quite often you will see this one repeated again. So perhaps in the 2026 exam.
Good. And just from everyone listening, so some of the problems with this question, again, that thing of vague definitions and terms, talk about tonicity, osmolality, colloid oncotic pressure, being used imprecisely. People were answering a different question, discussion of the physiological responses to a fluid load rather than the question asked, and also presenting the contents of the given IV fluids with no explanation of how this determines the distribution. So, to have that knowledge of what's in the IV fluids and not actually explain why it moves in a different direction or not. Yeah, it was not great.
Yeah. Now, if we move to the next variation question, this one was the most surprising. So, out of all the variation questions that were out there, I was shocked about how low this pass rate was.
So this is question 9. Describe the cardiovascular effects of sevoflurane, 27%.
Oh no, I think it was question 8. Sorry, question 8. There's another variation question.
Oh, the half-life context sensitive half.
Did I not put it down as a variation question?
That's in green. That's all right.
Apologies. Yeah, sorry. I meant to cover that as yellow. So if you could just move that as yellow, that's meant to be a variation question.
Yeah, great. So it says, question 8, discuss the concepts of half-life and context-sensitive half-time using fentanyl and remifentanil examples. Yeah. This sounds very familiar.
Yeah, exactly. Don't you think? And, when you look back at the previous question, 2015 B4 had a 58% pass rate. It was discuss the concepts of half-life and context-sensitive half-time with examples. And obviously, that one there, they didn't actually define what examples you need to use, but this one here, they did. And that was I would think, a very similar question. And then in 2005 B4 and 2001, it had defined the term context-sensitive half-time. How does it differ from half-life, typically quoted for a drug, illustrate with thiopentone versus propofol and fentanyl versus Remi. So you had that fentanyl and Remi aspect in that older question there. But suddenly 2015, it sounded like a very similar question with 58% pass rate. So I was, wondering whether you had any ideas in terms of why what I think is a straightforward question had such a low pass rate, relatively.
Yeah, I mean, luckily the examiners talk about the problems that are occurring. So, yeah, vague definition of context-sensitive half-time makes sense. If you don't have a definition of that, that's a real problem. And, I remember reading Pharmacology Made Easy or Pharmacokinetics Made Easy, and, the fact that time constants is, inherently related to volume distribution and clearance, and being able to define that would probably be very, very important.
Yeah.
Or superficial consideration of multi-compartment models. I mean, correct me if I'm wrong, but context-sensitive half-time is all because of the fact that we have multiple compartment models and redistribution, which is time-dependent from plasma to other tissues.
Yeah, and I think the point to make here is that the context in context-sensitive half-time is about the idea of the duration of infusion.
Yeah.
When you sort of talk about it in terms of the multi-compartment models. Now, the only thing that I can think of is that the threshold may have become higher. So what I mean by that is that when you think about the definitions, they may have required almost a stricter definition of what context-sensitive half-time is. And that could be the idea in terms of why there was that consideration that they were vague definitions. Because I was thinking, how could they be vague definitions? Because essentially context-sensitive half-time, to explain it, is just the time it takes for plasma drug concentration to decrease by 50% after you stop an infusion. And that has been maintained at steady state, where the context is the duration of infusion. Like, that for me is pretty straightforward. But if you actually break it down, you probably need different components in terms of what needs to be said in the definition for where the examiner will give a mark for. So, the first one would be the time it takes for plasma concentration to decrease by 50%. The second one has to be from discontinuation of an infusion that's been maintained at steady state. And then the third one is where the duration is the context, which is the context, is the duration of infusion. Yeah.
Yeah, excellent. Anything additional credit features of better answers, discussion of the underlying exponential process of half-life and relationship to volume of distribution and clearance. Yep, great. Graphical demonstration comparing fentanyl and remifentanil when well annotated. Great. That sounds like a good option there. And consideration of the clinical context of short and long infusions. Ooh, clinical context. So discussion of the concepts, and this doesn't always hit well for the examiners, but in this particular question, consideration of the clinical context of short and long infusions was rewarded, seems like. So, yeah.
It's a interesting idea where, I think that, that sort of where I think the exam is evolving. And I know that it's always been said that, things are always constant, but I do think that over time, the thresholds for what is acceptable probably increases. Don't you think?
Yeah, and because we talk about it, if this question is genuinely different, they would have had a marking rubric that's very not necessarily very specific, but they've got a marking rubric, and and that would be different to ones previously. So that makes sense.
Yeah, the best way I sort of think about this is, things that I learned when I was a lot younger are not totally different, but I think sort of definitely changed or evolved to perhaps what my kids or the younger generation is learning. And that makes sense. As sort of new knowledge comes about, you need to know more. And then things that you've learned in the past, they need to have sort of stricter ideas and stricter definitions in order to sort of gain those marks. So look, I think a learning point here is that with core concepts such as half-life and context-sensitive half-time, to really make sure that you minimize variations in how you answer that question. I think that's one of the key things, is that probably in the past, you could have some variations in terms of how you describe certain ideas. But I think core concepts such as half-life and context-sensitive half-time, I do think need to be strict in terms of their definitions. Yeah.
No, that's fair. Next one. This is very surprising to me. Describe the cardiovascular effects of sevoflurane. 20% pass rate.
Yeah. So this one here, again, very, very low, 27%. But look, I understand, like it goes back to the idea where I think that if you look at the previous questions, there have been ones in the past where you had multiple components to it. But all of a sudden, not say all of a sudden, but the main focus here, you think about it, is on one system and one drug. And to highlight this, let me sort of show you what the previous questions were. So 2020A, which had a very relatively low pass rate, 31%, it was compare and contrast the effects of sevoflurane and nitrous on the cardiovascular system. So you didn't have to just talk about sevoflurane. You could also talk about nitrous as well. So, you could talk about sevoflurane for 5 minutes and nitrous for 5 minutes. Now, 2011B1, which had a pass rate of 66%, compare and contrast the clinically significant cardiovascular and CNS effects of DES and Sevo. So again, you could spend 2.5 minutes on CVS for Sevo, 2.5 minutes on CNS for Sevo, and then 2.5 minutes for CVS and DES, and then 2.5 minutes on CNS and desflurane.
Less depth required for each.
Correct. And I think that's the catch, is that here you need that depth. It's no longer about breadth, but you're looking at depth. And I think that's been one of the key things that I've picked up in this exam here, is that there has been that focus on depth with certain topics, and the only one that I've seen with depth in terms of a previous question in the past, the 2008 B1, had outlined the potential beneficial and adverse effects of ISO on the CVS system. And obviously, I think ISO is pretty much defunct. I don't know. Have you used ISO recently?
No, not at all.
No. Tends to be used in, sort of countries where cost is a factor. It's one.
Actually, I was in the Solomon Islands and they had, ISO. That was their one.
Yeah, ISO and I think the other one's halothane that they often use as well. But yeah, ISO is definitely a lot cheaper. And I know that if you do the real world anesthesia course, they use a lot of ISO there. But, that question there was solely on ISO. And to be fair, a lot of the effects that ISO has on the cardiovascular system, you could actually apply it to Sevo as well. There's a lot of similarities between them both. So I think if you did that question, that one then in 2008, you would have been able to cover this question. But 2008, what were you doing in 2008?
Studying for this exam.
Exactly. I think this was my question. 2008 was when I set this exam, B1. So this was my question that I did and brought back memories.
A real warm and fuzzy moment of that.
So just everyone out there, just goes to show how old I am. So 2008 was when I set the primary exam.
I might just put this up if you can see this on YouTube channel. So we have the cardiovascular effects of inhaled anesthetics, and here we have sevoflurane and contractility. So they specifically say use the domains or the indicators of myocardial performance or determinants of myocardial performance. So contractility, decrease, heart rate, nil effects, systemic SVR, decrease, blood pressure, decrease, coronary steal syndrome, no, spinal blood flow, unchanged, sensitization to catecholamines, nil. So kind of underwhelming. One of the reasons is sevoflurane, it is underwhelming on the cardiovascular system. So great. That's good to know.
Yeah. So the next variation question was on question 12. And I thought this was well done. I am compare and contrast the pharmacology of metaraminol and ephedrine.
Yeah.
And I always say, compare and contrast questions in the exam are the most difficult structurally to answer, because a lot of us, and I'm sure that when you went through, would want to do a table, right?
Mm-hmm.
But tables don't work here.
You don't get to write information about, like, words to, I guess more than just one word is required for compare and contrast.
Well, it's funny here. It goes additional credit and features of better answers. A table format was often used to good effect in a lot of answers. I will tell you, right? When you think about compare and contrast, what does that mean to you?
Yeah, because I think I agree with you that I think a table doesn't work that well because it's not two columns. It's a domain.
Yeah.
And it's actually just a listed domains of things.
Correct.
And then talk about both in a dot point paragraph form or whatever.
Yeah, you're not actually talking about the both. I can tell you what often happens with a table. Often a table is like you just write your topic. So let's say your pharmacology is absorption, distribution, metabolism, elimination, and then you have metaraminol, ephedrine, and then you just write ideas for each one.
Yeah.
Right? But you're not actually comparing and contrasting. And if you look back at the definition of comparing and contrasting in the exams report, comparing is looking at the similarities and contrasting is looking at the differences. Yeah. So when you look at a table, you can't just have 3 columns. You actually need to have, if you want to do a table, you need to have 4 columns. Now, I don't know about you, but have you ever tried producing 4 columns in that exam paper?
Or 2 columns, similarities and differences.
Well, the key bit is how would you distribute it in terms of absorption and distribution metabolism?
As in 3 columns in the sense of each of your parameters on one side, similarities, differences. That could work. But could. I like the idea of just having, in this case, physicochemical, great. Both are clear cold solutions. These are the formulations. Done. You've done your similarities.
Correct. So what I will say to that is, have you ever tried doing similarities and differences with that table format? Because what do you think you'll end up doing most of the time?
As in, if you were to do a column for metaraminol and a column for ephedrine, you'll just repeat information. That's why. You know what you would repeat? You would keep on repeating the words metaraminol and ephedrine. You would go, metaraminol is different from ephedrine because of. Ephedrine is different from metaraminol because of. Yeah, it's always right? That's why if you were to do a table, just having similarities of these two, you don't have to repeat the words. So
yeah, similarities is fine. I agree. But when you think about differences, you're going to be repeating the words metaraminol and ephedrine, and it can be very, very challenging, putting in those words over and over again.
As in, if you had a differences column, metaraminol, ephedrine differences, I would similarly not need to repeat the word because I'd say the differences are this, this, and this.
Yeah. Yeah. I've always said, I think the best way to do compare and contrast is to look at it just in terms of actual paragraphs. So when you think about absorption, under the 2, you could have what is similarity in terms of absorption, what are the differences in absorption? When you think about distribution, what are the, your first word could be, this is similar. And then your second word could be, these are the differences. I think that's a better way to do it. But in saying that, I have to acknowledge the examiner did like the table. So for all those who do write put the table out there, the examiners liked it here, right? Yeah.
Interesting. And just so additional credits to table format, they did like, if it was done well, I see. Better answers were able to elaborate on points of clinical significance when using each drug. So there's another vote towards saying the clinical relevance of whichever pharmacodynamic or intramuscular is a useful thing for ephedrine, but doesn't really work or isn't commonly used for metaraminol. And what are the clinical significance of that? That's good to be able to. It's good to be able to add that as well.
Yeah. And look, those are all the variation questions that are out there. And I think that a learning point that we can sort of hopefully look at and implement some changes that can help us improve, our performance in the future is when you look at repeat questions, think about it in terms of what possible variations there could be of those questions there. Because it's clear to me that when candidates are, presented with a different form of the question, that perhaps phrased differently or including other sort of topics that are out there, they do struggle with that.
Yeah, interesting. Hey, is there any other questions you want to go through?
Well, I thought if you go back to the table that's there, The one that I've got just a summary in terms of what's repeat, what's new, and what's a variation. I think what was really promising was that, a number of the new questions were actually done fairly well. And perhaps there were new questions on core topics because, like question 5, which had a pass rate of 51%, that was on peripheral and central sensitization. So if you look at the question that was there, which is question 5, outline the mechanisms of peripheral and central pain sensitization. Now, this has always been a Viva topic to me. So it's really interesting to sort of see now that they've put this into a short answer question.
Yeah, the Viva topic is always lead generation for
correct.
It always gets direction.
And I think it was really good that that candidates actually did really, really well in this question. You can sort of see that with that 51% of candidates passed this question. So that was a very, very strong performance that's there. And perhaps that would be something that would be a consideration is that, a lot of the new questions that come out, and let's have a look at another one. What was another new question?
And
it was
blood glucose regulation.
Blood glucose regulation. So that one there was also done very well. Explain how blood glucose levels are regulated for the duration of a 48-hour fast. And look, there have been sort of similar questions in the past, but not specifically on blood glucose regulation. So the ones that have been sort of asked about fasting in the past were about compare and contrast the physiological effects of a 6-hour fast of fluids and food with a 24-hour fast in a healthy adult. And then the other one was describe the few sources used during early and sustained fasting in humans. So not really, sort of really focused on blood glucose regulation. But I think what's the really interesting point is that a lot of these repeat questions are almost verbatim from the learning outcomes. Don't you reckon? So like if you had covered the learning outcomes there, and if you go back and look at the pain one, they had like just one learning outcome that was there. I think if you had covered that learning outcome, you would be able to answer, this question here. So I think, again, a learning point here is that the learning outcomes are serving as the basis of new questions moving forward.
Yeah, absolutely.
And I think there was one last new question on...
dabigatran and rivaroxaban. So question 13.
And that was on a number of anticoagulants, actually.
Here we go. Outline the pharmacology of the following anticoagulants: dabigatran, rivaroxaban, using the following headings. That's very nice of them. Mechanisms of action, important pharmacokinetics, time for offset of effect when ceasing preoperatively, and reversal. I really like that they give the headings. It makes it a far more objective paper, I think.
You think so?
Yeah, and there's no ambiguity about what do they what do they mean by pharmacology? What going to score more than the others? Like, imagine someone wrote a whole bunch of great detail about absorption, but the examiner's preferenced, actually we want the pharmacodynamic effects. That's what we care about. But the question hasn't given a prioritized framework for that. So I think it's great that they're telling you that. And
it's such an interesting idea. And probably I'm sort of going off on a tangent here, but sometimes I think, right, the ability to actually know what the framework is actually part of that creating a good answer. Does that make sense?
I agree with that. It's just that I think that candidates shouldn't have to mind read what the examiners believe is important when the question is just a question. It didn't say, what do you outline the most clinically significant pharmacology? That's a different question. So anyway, I just like when things are as objective as possible, because we've all seen incredible variability answering questions, whether we're answering it or the examiners are answering it. It's just so variable.
Yeah. Agreed. So look, I think that if you look at this new question here, again, straight from a learning objective, describe the pharmacology of warfarin and other anticoagulant drugs. So looking at that learning objective, if you had sort of done a cart for that,
yes,
you would have been able to sort of cover dabigatran and rivaroxaban. And it's a lot, isn't it? I must say. Like,
yeah.
I know that in some ways people say that, with time and resources that the exam should be easier. But there's no doubt, right, that I think that the amount of information out there has increased. And I feel that almost the threshold of what is required to pass, I think is definitely increasing. What are your thoughts?
I agree. Imagine doing this exam back in the 80s, not having propofol, potentially not having remifentanil. There's no context-sensitive half-time question. You don't learn the 3-compartment model. Maybe you do it, maybe you don't. And we've got so many more drugs. And I mean, the way the Optel exams have gone is they've broken it up into multiple exams. And potentially that's how it's going to go.
Well, they did that in the past. In the past, what they used to do was they used to do the phys and pharm as separate exams.
Yeah, I mean, you had the option of doing it separately, but a lot of people did it together. But to actually go, we're testing, cardiovascular agents and volatiles, then
right,
like multiple smaller stakes exams. I get the sense that's the direction things go when things get so ridiculous with the amount of knowledge that you need to learn. But who knows? Yeah.
Now, we do have an audience here. So if they have any sort of questions, they can put it in the chat while Lara and I are continuing on sort of discussing about these ideas here. And I think, when we sort of look at the learning points in terms of what we can, come out of this exam and from this examiner's report, and I give credit to the actual report itself. I think it's very detailed, very helpful.
You want these to be helpful and people can learn from the exams. And that's one of the greatest part of the exams, that it's exercising learning and, teaching the next generation to how to learn and do better for the exam as well. So,
yeah. And I always get asked, do you focus on repeat questions or do you focus on learning objectives?
We always talk about that, don't we?
Yeah. It's such hard,
as in the
approach.
The logic is that, so I studied from short answer questions. I think Stan studied from learning objectives.
No, I actually did short answer questions
as well.
As well. But the thing is, I also did learning objectives, but I will preface it in terms of saying it took me more than 12 months.
Yes. Okay.
So I studied for 18 months.
Yeah, right.
For this exam. And I know that the consensus out there is that, you do need to study for 12 months for this exam. And definitely you can do it in 12 months.
You can probably get to a different level of understanding. You have the, energy to do that ultra marathon of 18 months versus 12.
No. And look, to be fair, when I was planning to do this, this was a time where you could sit the exam before you got on to the anesthetic training program. I don't know whether when you entered, that changed.
No, we also started studying in our critical care unaccredited year and then sat the first sitting.
Yeah, so this was different. So when I went through, you were still allowed, and they were changing it at that time, you were still allowed to sit the exam before you got onto anesthetics. So what a lot of candidates used to do was try to sit the exam to get it as part of their application.
Yeah,
was getting into anesthesia.
You could get a job if you pass the exam.
It's a massive hurdle, isn't it?
Yeah,
and there's nothing better for a hospital than having a trainee that's passed the exam, because, I think that's one of the really challenging aspects of this exam and the pass rates that are out there. And we can talk about this on another podcast, just with regards to the support that's required when you look at a pass rate of just 62%. Yeah. That means that 4 out of 10 didn't get through this exam. And that's an incredible high number.
Yeah. Imagine the logistics of writing an exam for that.
Yeah. So going back to my story in terms of the preface of why it was 18 months. So when I was thinking about doing anesthetics, that was one of the aspects where, I was looking at hopefully passing the exam before I got into anesthetic training program in order to boost my chances to get onto the program. So I actually started studying in lieu of, sitting the exam in actually July the previous year. But obviously that sort of didn't work out. And, I took a bit of a short break and then sort of aimed at for sort of July the next year. And in actual fact, it wasn't just the 2 exams I could just sit 1 exam. And I remember I had just focused on physiology exam for that July 2027 B. So in the end, sort of pushed it towards 2008 B.
Yeah, right.
Yeah. Yeah. So look, I think in terms of, whether you do exam questions or learning objectives, one of the really key factors that we don't talk about is time. If you had unlimited time, yes, learning objectives and definitely short answer questions. But with the concept of that your time is limited and there's opportunity cost, you're going to have to choose, a hybrid that's going to sacrifice one or the other, right? And is there a right or wrong answer? I don't think so, because I've seen people pass with both techniques. Don't you think?
Yeah, absolutely. And I think one of them is when I looked at the basic physiology objectives, there's just never been a question on some specific protein receptor or whatever. I'm like, look up. I know that I don't have to spend as much time learning that as learning compliance.
Yeah.
So it just helps you to prioritize, how much time you're going to spend. So you can definitely go through learning objectives, but if you were to cross-reference that with the short answer questions, it'd give you a sense of where to spend your time.
Yeah. And I think the most ideal situation would be, if you were able to do the short answer questions that have been done in the past, to hopefully tie it into the learning objectives, and not only think about it in terms of the answers that would be required to answer that question there, but also the depth that goes into each learning objective, because it's quite evident in this exam here that they've really focused on depth here.
Yeah, absolutely.
Yeah.
Hey, Stan, just because we're coming up to time, is there anyone, any questions? Oh, here we go. Do you think there would be issues with a 4-column answer with, say, 1 factor small, 2 ephedrine, 3 metaraminal, 4 significance?
So what I would say to that is I would trial it before doing it. So this was a question from the chat about the compare and contrast, doing 4 columns. And what I would say to that is make sure that you can do it effectively on the exam paper, because you and I know, that exam paper is very different from everyday paper. That exam paper comes from like a 12-year-old textbook, don't you think?
Yeah, absolutely. Hey, just to answer your question, I just don't think having an ephedrine and metaraminal column works, because then you'll say ephedrine has similarities like this to metaraminal. Metaraminal has similarities like this.
That's right.
So
correct. You're repeating yourself.
So what I'd say is have a factor and then similarities, differences, significance if you want to do that. I can see that working. But also if you just had factor and then wrote under that factor, these are the similarities, these are the differences, right, and there's a clinical significance, you have more space to write. And in the really weird exam paper, that might work better. But again, like Stan said, just trial it out, see what works for you, because the exam paper is just the real estate of the exam paper might be the thing that turns you one way or the other. Yeah. Agree. Great question.
Now my last bit, the last couple of minutes that we have here, my prediction for August. So it's quite interesting when you look at the distribution of questions that were here. There was 1 anatomy and 6.5 physiology, 6.5 pharmacology, and there was not 1 true equipment question. So the equipment question was really tied into both physiology and pharm. So if you look at the half equipment question.
Pulmonary artery catheter, is that
correct? Yeah. Well, I mean, would you consider it as equipment or would you consider that as part of cardiovascular physiology? It's a bit of both, isn't it? Don't you think?
I'm trying to think where I learned waveforms.
I learned waveforms in cardiovascular physiology.
Yeah, I'm not going to weigh in on it. But
in fact, there's a very good subset in Brandis, and that's a shout out, obviously, to Brandis's book, his physiology book, which actually talks about the pulmonary artery catheter waveforms, and that itself is a physiology book rather than equipment. But I have included this as half an equipment question, right? But it's not a true equipment question.
Yeah.
And then the other half equipment question was on neuromuscular monitoring, so the blockade tests. So there wasn't a true equipment question on this exam. And if you look at previous exams, there have been true equipment questions. So my prediction for August, and obviously it's a small one, is that there will be a true equipment question there.
Okay. Learn equipment well.
Learn equipment well. But the other, interesting bit is that, phys and pharm is always 50-50. And they seem to be really sort of making sure that they cover sort of the main topics in terms of respiratory and cardiovascular. So I think we can sort of safely say that, there will be sort of one of each, at least in some form or the other, in the next exams. Yeah.
Hey, just in the interest of time, let's crack on. So I've got to go very soon. So recommendations for candidates?
And I think we've discussed this already, is that, when you look at repeat questions, I think it's still key in terms of, your preparation for this exam. If you can tie it in with the learning objectives, look at it in terms of the depth that can be sort of required to answer sort of subsets of the learning objectives that may be sort of tied to previous questions. It is going to take time. And this is where study group is really helpful. Yeah. I think if, you can able to distribute that workload, that is of great help. But the other aspect is you may need more than 12 months to study in this exam. And that's okay. I took 18 months, to study this exam.
And I like what you said here as well. Identify and proactively teach new and emerging content areas to improve candidate performance. So,
No, that's the recommendation to you, La. That's the recommendation to supervisors. That's not just the candidates.
So that's your recommendation for us.
For us, yeah, correct. Yeah.
So flows-ins, SGLT2s, it's all going to be very soon examined. So might as well get
right.
Rid of it.
Yeah, correct. And I think, in this day and age of AI, I do encourage you to utilize it. And one of the ways is perhaps to put in the questions that have been asked in the past and perhaps ask AI to think of variations of the questions that could occur. I think that's really, really helpful. So, very important to sort of hopefully leverage your learning and create that efficiency you need to help you save time and actually cover the content that's out there.
Sounds good. Hey, thanks so much, Dan. That's all very good. Thanks everyone for watching and listening. Please share with anyone who might be interested. That was the highlights of the 2025 first sitting paper. See you next time.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.